Okay, dear students, good evening. Can you hear me now? Acha, okay. Yesterday we learnt about the disease of the prostate. In that we learnt about the benign prostatic hypertrophy. Today, let us study about the other disease of the prostate, the blood outflow obstruction. That means whenever the obstruction to the below the level of the bladder neck is present, we call it as bladder outflow obstruction. There are two conditions which we have to learn. That is there, number one, the Marian disease, that is called bladder neck hypertrophy. Then bladder neck fibrosis. So bladder neck hypertrophy means the internal urethral sphincter becomes hypertrophic and that causes obstruction. Bladder neck fibrosis means the internal urethral sphincter is being replaced by fibrous tissue and there is a lot of fibrosis. Usually this follows prostatectomy operation, including TRP. The treatment is, for the bladder neck hypertrophy, you can give alpha adrenergic blocking agents because the internal sphincter is under the control of the sympathetics. So you give alpha adrenergic blocking agents. They cause relaxation of the sphincter. Transurethral incision is given for the bladder neck. This divides the bladder neck muscle fibers. The hypertrophic muscle fibers can be incised. Next is the carcinoma of the prostate. Carcinoma of the prostate arises from the posterior lobe of the prostate, which contains the prostate glands proper. When you look at this cross section, this is the urethral glands zone. The middle one is the transitional zone. The peripheral one is the prostate glands proper zone. So from this area, the prostatic cancer arises. Hence, prostatectomy done for BPH doesn't give immunity from carcinoma. We have seen these lobes get hypertrophic in BPH. What we are doing, either in transurethral resection of the prostate or in open surgery, we are enucleating those enlarged lobes, the both lateral lobes, and if medial lobe also is enlarged, that also is being enucleated. That means you pass the scope into the urethra, you cut away the slices. So you scrape the prostate gland till all the adenomatous tissue has been scraped away. Then the remaining one is the compressed prostatic posterior lobe. This compressed posterior lobe contains the prostate glands proper. So in TURP, you are not doing complete removal of the prostate gland. You are removing only the enlarged prostatic lobes. So the posterior lobe is left in place. So from the posterior lobe, the carcinoma of the prostate can arise. So this is the zone where carcinoma develops. It is an adenocarcinoma. Gleason's grading. The Gleason's scoring system is the most common prostate cancer grading system used. The pathologist looks at how the cancer cells are arranged in the prostate and assign a score on a scale of 3 to 5 from two different locations, and both are added to get the total score. That means you must take multiple biopsies from the prostate gland, and each biopsy is being studied by the pathologist. Depending upon the differentiation of the cells, you know the meaning of differentiation. Well differentiated means they resemble the normal prostatic cells. Less differentiation or de-differentiation means the cells have no resemblance to the normal prostatic gland cells, and they have either oval or round cells with very large hyperchromatic nucleus. So basing on that one, it is being graded from 3 to 5, because 1 and 2 are the normal prostate gland tissues cells. 3 means well differentiated, 4 means moderately differentiated, 5 means ill differentiated. So like that, you give the scoring. The pathologist will give scoring. He will take 2 samples. Samples taken at one place, that is being scored, and you have to send another bottle, another piece taken from another place. So that also is taken. These 2 scores are added. For example, in the specimen A, the score is 3. In the specimen B, the score is 4. So the total score will be 7. Cancer cells that look similar to healthy cells receive a low score. That means 6. 6 is having the well differentiated cancer cells. 7 to 8 means moderately severe. 9 to 10 means highly malignant cancer. Spread of the tumor, local spread, upwards. The prostate cancer can spread to the seminal vesicles, bladder neck, bladder trigone, and lower ends of the both ureters. Downwards, it can infiltrate into the external urethral sphincter. Behind, it can encase the rectum. Lateral, it can spread up to the pelvic wall. Blood spread, particularly to bone, causing osteosclerotic and osteolytic secondaries. Usually, many of the secondaries in the bone, they are all osteolytic. But the prostate cancer has an ability to produce secondaries which cause osteosclerosis. That means normally osteolytic means there is a cavity in the bone. Wherever the secondary develops, at that place you will find a cavity. Osteosclerotic means at that place you will find more thickening of the bone. Then lymphatic spread. Lymphatic spread is to the internal iliac and external iliac lymph nodes. From there, they spread to the retroperitoneal lymph nodes around the aorta, and from there, they spread to the thoracic duct, and from there to the Virchow nodes. Clinical features: age more than 65 years. In Indians, it occurs at an younger age. Symptoms: symptoms of prostatism are lower urinary tract symptoms. That means the same symptoms of BPH will be there here. That means the frequency, the urgency, the urge incontinence, hesitancy. Then hematuria, pelvic pain. Pelvic pain occurs whenever there is infiltration to the surrounding organs. Chronic retention of urine, just like in BPH. Now and then patient can get acute retention of urine. Bone pains due to secondaries which may be osteosclerotic or osteolytic, and pyrexia of unknown origin. So most of the clinical manifestations of the BPH and carcinoma of the prostate are similar. There is not much difference. That is why by symptomatology, by age of the patient, you cannot make a differentiation between prostate cancer and BPH. The signs on clinical examination, there may not be any feature in the early stages. Distal rectal examination may show a small nodule in the prostate. The nodule will be hard in consistency and not tender. Already we have discussed about the median sulcus yesterday class. So there will be obliteration of the median sulcus of the prostate is a diagnostic feature. Why there is obliteration of median sulcus in carcinoma of the prostate? Why is there median sulcus obliteration? Yes, it is because of the posterior lobe involvement. Hard nodular prostate with fixed to surrounding structures in advanced lesions. Staging of carcinoma of the prostate. T1A, incidentally found tumor involving less than 5% of the resected specimen of BPH. That means you clinically it looks like BPH. On clinical examination also it looks like BPH. You do TURP. So probably the patient is having BPH only. You do TURP and you send those resected specimen to pathologist. So the pathologist will examine and find that less than 5% of the resected specimen of BPH has histology of carcinoma. T1B means incidentally found tumor involving more than 5% of the resected specimen of the BPH. So patient is having BPH as well as carcinoma also. So both can coexist. So when you scrape, sometimes the posterior lobe may also be scraped. So that may show the carcinoma. T1C, impalpable tumor after detection of raised PSA. So usually more than 60 years, if any person with urinary symptom comes to you, or even as a general health surveillance, you must do PSA test, prostate specific antigen. It is a tumor marker of the carcinoma of the prostate. So if you do it in general population once in every year for the male patients more than 60 years, some books say more than 50 years. If it is elevated, then you must do digital rectal examination. If any suspicion is there, then you must do transrectal ultrasound. So T1C means PSA is elevated. Clinical examination doesn't show any nodule in the prostate. Then T2A, nodule in one lobe confined within the capsule. So this is T2A, where the lesion is there confined to the capsule. T2B, nodule involving both lobes. T3A, spread through the capsule outside. T3B, spread to the seminal vesicle. T4, invasion of the adjacent structures, rectum or pelvic wall. If this nodule, if it projects anteriorly, then what will happen? It will present like a mass projecting from the posterior lobe. So when you are doing TURP for BPH, that means when your lateral lobes are being enucleated, you will see a mass-like projection. You will think that that is also part of the BPH. So you will scrape that. That is how you will get the T1A. So when a small nodule arising from this region, that means at the junction of the posterior lobe with the middle lobe, lateral lobe, so that projects into the lateral lobes. So then the endoscopist think that it is also a lesion of BPH and he will scrape it. That is how the carcinomatous lesion also will be scraped along with the BPH. End staging, N0 no nodes, N1 pelvic lymphadenopathy, internal and external lymph nodes. M staging, M0 no metastasis, M plus means metastasis. Investigations, biochemical investigations. Acid phosphatase is elevated in carcinoma of the prostate. Nowadays, PSA, prostate-specific antigen, a serine protease secreted by the prostate, which assists liquefaction of the semen. So this particular enzyme is of is having more significance now. It is tumor marker for carcinoma of the prostate. It is useful for screening the cases of carcinoma of the prostate. So as I told you, persons more than 50 years of age, in some countries 60 years of age, they are being advised to have PSA test every year. If it is found to be elevated, then they should consult the doctor for evaluation of carcinoma of the prostate. Because prostate is one of the commonest tumors occurring in the male population. Normal is less than 4 nanomoles per ml, and if it is more than 4 nanomoles per ml, transrectal ultrasound scanning of the prostate is done, and any suspected areas are biopsied under ultrasound guidance. More than 10 units is highly suggestive of carcinoma, and more than 35 is suspicious of widespread secondaries. There are some false positives in PSA elevation. It can be elevated in chronic prostatitis, BPH, sometimes after distal rectal examination, as well as after intercourse. But now, many studies have shown that distal rectal examination will not influence PSA. Okay, Shruti has a doubt. Say the right or left. When you do distal rectal examination, you will feel the whole posterior surface of the prostate. There, you can make out whether you are feeling the right side or left side. Of course, in that image, you cannot say. But for a patient, when you are examining as a physician, to feel the lobes, the posterior lobe as a triangular structure. So when you are feeling, if you feel a nodule, you can say whether it is there on the right side or left side. Right side, not right lobe or left lobe, right side or left side. That is only for description, that's all. It won't make any influence in the treatment. Then coming to the investigations, alkaline phosphatase. It is elevated if there are bony secondaries. Not only with prostate bone secondaries, any secondaries in the bone is associated with, that means from any lesion, from any source, the alkaline phosphatase is elevated. Can you tell me the common sources of secondaries in the bone? That means from which organs the bone secondaries usually occur? Which cancers will produce bone secondaries? Tell me some lesions. There are only 5, so you must remember them. That's very important also. That's very good. Yes, very good. One more, one more. No, it's not brain. thyroid, breast, lung, prostate, and kidney. So these are the 5 organs which commonly metastasize to. I repeat: thyroid, breast, lungs, kidney, and prostate. These have predilection to spread to the bone. So whenever bone secondary is there, alkaline phosphatase is elevated. Gamma glutamyl transferase is elevated in liver secondaries. Then imaging studies, transrectal ultrasonography, abbreviated as TRUS. This is a very important investigation in prostate cancer evaluation. So when you do ultrasonography by passing the probe through the transrectal route, you can evaluate the prostate for the local extent of the lesion. Then MRI scan of the pelvis, it is the most accurate method of staging the disease. That means you can make out T stage as well as N stage with MRI scan of the pelvis. X-ray of the chest for secondaries in the lung. X-ray of the pelvis and spine for bony secondaries. Ultrasound scan of the abdomen for liver secondaries. Then isotope bone scan for bone secondaries with technetium-99m, especially in cases with PSA of more than 10 nanomol per ml, 10 nanomoles per ml, or locally advanced disease, or Gleason score is more than 7. So in these 3 conditions, you have to go for isotope bone scan for evidence of any bone secondaries. So this is the transrectal ultrasound, and you can make out the hyperechoic lesions in the prostate gland. So this is the incidence of carcinoma, prediction of carcinoma in the bone. So it usually metastasizes to the pelvic bone, then to the spine, then to the upper ends of the long bones. Then there will be secondaries in the ribs and secondaries in the skull. So these are the common sites of metastasis in the bone. So you can see here the multiple metastases. These are all osteolytic secondaries in the pelvic bone and femur. So these black areas are all the osteolytic areas. So there are multiple secondaries. This is bone scan with technetium. So all these black areas are called the hot spots. So wherever the technetium, radioactive technetium is concentrated, that is the area of bone secondary. So by transrectal ultrasound, you can make out the T staging. Usually the lesion appears as a hyperechoic nodule. But MRI scan will help you to know about the external iliac and internal iliac lymph nodal metastasis, and to collaborate the transrectal ultrasound findings. So for that reason, MRI scan is being done. Once you do transrectal ultrasound scan, you find a nodule there, then what you do is you do biopsy. The biopsy can be done by passing the needle through the perineum or by passing the needle through the rectum. But whatever you do it, you must do it under guidance. So you see this nodule and you aim the nodule and you take the biopsy from the nodule. So transrectal or transperineal biopsy with the help of Wim-Silverman's needle or true cut needle is taken. Treatment of carcinoma of the prostate, incidentally discovered disease, that is T1A. That means there is no clinical evidence of any BPH, there is no elevation of PSA, the patient presented to you with symptoms of BPH, and on ultrasound scan you find BPH. So you did TURP for the patient. When the TURP specimen is studied, there is evidence of tumor. That too only in less than 5% of the specimen that is sent. So in that case, what you do active surveillance. This is a procedure called active surveillance. What is that active surveillance? Incidentally discovered disease is monitored by 3-monthly digital rectal examination and PSA examination. So the patient is followed up with digital rectal examination. That means for any evidence of nodules or for any evidence of PSA elevation. If there is evidence of disease progression, it is treated as described for T1B and T1C disease. So when you do digital rectal examination once in every 3 months, you find a nodule in the prostate. Then you must give the treatment what you are going to give for T1B and T1C disease. Low risk disease. Then second group is low risk disease. That means where PSA is low, less than 5 units, Gleason score of 6, and there is a small focus in the prostate. So in this case also, you go with the active surveillance. For T1B, T1C, T2, N0, M0 lesions. If the patient is fit for surgery, go for radical prostatectomy or give him radical radiotherapy with the help of external beam radiation or by brachytherapy. If the patient is not fit for a major procedure like a radical prostatectomy, then you give radiotherapy or hormone ablation therapy plus TURP if there is bladder outflow obstruction. If the patient is not fit for radical prostatectomy, you go for radiotherapy or hormone ablation therapy. T3 and T4 lesions, palliative hormone ablation therapy. In younger patients, androgen ablation therapy with radiotherapy is preferred in T3 patients. For other, androgen ablation is advised. What is hormone ablation therapy? Hormone manipulation is done to reduce the action of testosterone on the prostate gland proper. We have already seen that testosterone is necessary for the growth of the prostate gland, for maturation of the prostate gland. And this prostate cancer is hormone dependent tumor. That means when hormone is present, it grows. If hormone is less, it reduces. So what you do is you manipulate the testosterone. So how do you manipulate testosterone? By surgery or by drugs? Other diseases where the hormonal manipulation is done to treat them are the carcinoma of the breast and thyroid. So in these two other conditions also, hormone ablation or hormone manipulation is done. Surgery. How to reduce testosterone? By removing both the testes. Bilateral arthrectomy with or without adenectomy is done to deprive the testosterone production. Now we have powerful hormones which can block the testosterone. That is equivalent to doing the arthrectomy. By giving estrogen analogs like stilbestrol, they decrease secretion of LHRH by stimulating the hypothalamus. So when stilbestrol is given, either stilbestrol or testosterone, both of them has a reflex feedback mechanism on LHRH. So when stilbestrol or estrogen is increased in the body, the LHRH is automatically decreased. So when LHRH is decreased, testosterone production also is decreased. So when testosterone is not there, there will be atrophy of the prostate and atrophy of the testis. This estrogen therapy was started in the earlier days, but now we have a lot of substitutions for this because estrogen therapy produces painful gynecomastia, sodium retention, and predisposes to deep vein thrombosis. So because of these features, you don't use stilbestrol nowadays. So then there is a modified stilbestrol that's called HON1. It is the phosphorylated diethyl stilbestrol. The active form of the drug is stilbestrol. It is released in the prostate due to action of acid phosphatase on the drug, and hence the systemic effects like gynecomastia are not present with this drug. We have seen that prostate contains acid phosphatase. So this is a phosphorylated stilbestrol. So it is not active in any part of the tissue, any part of the organ. So where acid phosphatase is there, the acid phosphatase is exclusively present in the prostate. That acid phosphatase enzyme splits this phosphorylated diethyl stilbestrol into plain stilbestrol. So now stilbestrol will be active in the prostate tissue. So its action is confined to the prostate gland. So that is HON1. Now the testosterone produced usually is low in elderly people. Even that low amount of testosterone can cause progression of the prostate cancer. So the testosterone is produced from the testis as well as from the adrenal glands. So you want to make testosterone almost nil. In that condition only, the prostate cancer regresses. When compared to the adults, it is low. But even that low amount of testosterone can cause carcinoma of the prostate. It is not causation, it causes progression of the lesion. Exact cause of carcinoma of the prostate is not known. It is not due to the hormone excess. It develops. Why is not known. But it is hormone dependent. When hormone is available, it progresses. When hormone is not there, it regresses. So that is why you give anti-testosterone therapy. So one is stilbestrol, the next is the phosphorylated diethyl stilbestrol. Then testosterone receptor blockade drugs. There are testosterone receptors in the prostate gland. So you block those receptors like furosemide, cyproterone acetate. They block the testosterone receptors in the prostate, making the gland non-responsive to the hormone. Then we have the powerful LHRH agonists. LHRH is released in a pulsatile manner with short half-life. So normally LHRH is released in a pulsatile manner. It will be more, then decreases, then again it increases. So there is a waveform for its secretion. So when it is in waveform only, it is active on the receptor organs. Its receptors are desensitized if permanently stimulated. These LHRH agonists act by this mechanism to block the receptors and thereby reduce its secretions. So this is how LHRH agonists will act. So these LHRH agonists, they do not cause hypersecretion of LHRH. They cause continued secretion of LHRH. So when there is continued LHRH secretion, the receptors where it acts, they get desensitized. So there is no stimulation from LHRH. So that is why there is no secretion of testosterone. There will be a surge in the testosterone initially, followed by fall due to the blockade of the pituitary. The other group of hormone blocking drugs are the androgen production inhibitors, that is the aminoglutamide. In treatment of secondaries of the bone, isolate lesions, external radiation, disseminate bone secondaries, give radioactive strontium. Complications of radical prostatectomy: erectile dysfunction because of injury to the neurovascular structures of the erectile mechanism, which pass close to the posterior wall of the prostate. Then there may be stress incontinence because of the sphincter disturbance. Then the prostatitis. Prostatitis is the inflammation of the prostate, types acute and chronic. Chronic, it can be specific or non-specific. Acute prostatitis, it is due to infection with Escherichia coli, Staphylococci, Streptococci, and Gonococci. Source of infection: hematogenous or ascending from urethra. Clinical features: acute prostatitis. General features manifest predominantly in form of fever, chills, and rigor. Local features: pain or heaviness in the perineum, scalding micturition, and passage of threads in the urine. Distal examination will reveal a tender prostate. Treatment: prolonged antibiotic therapy with those that are secreted into the prostate, like trimethoprim and ciprofloxacin. Sequelae: prostatic abscess, epididymitis, cystitis, chronic prostatitis. Treatment of chronic prostatitis: you have to use the antibiotic for a prolonged period. That means sometimes it may be for 2 to 3 months. And prostatic massage to expel its prostatic secretions, because we have seen that prostate gland, in the prostatic urethra, you find multiple openings of prostatic glands. So when infection occurs in any of these glands, the bacteria can reside. So if you give antibiotics, they cause destruction of the bacteria. If they are not responding in spite of giving treatment for a few months, then what you do is every week the patient is advised to come and you do distal examination and then do prostatic massage. So when prostatic massage is done, the prostatic secretions are expelled out. So when the secretions are expelled out, automatically the contents of the secretion, that means the microbes, also will be expelled. So once they get expelled, if you use the antibiotics, they work more efficiently. So this is the prostatic massage. But some reports say that this prostatic massage is of not much helpful in treating chronic prostatitis. The tuberculous prostatitis, it is rare and usually associated with seminal vesicle infection. Presentation: discharge per urethra, painful or blood-stained ejaculation, then mild pain in the perineum, infertility, then abscess. On examination, you will feel fibrosed seminal vesicles. So they feel firm masses. The description is called as the craggy seminal vesicles. Treatment is antituberculous treatment, sequelae, tuberculous epidermolysis. Prostatic calculi types: exogenous calculus, that means calculus which is coming from the bladder. If it gets impacted in the prostatic urethra, that is a type of prostatic calculus. Then endogenous means calculi formed within the ducts of the prostate. In chronic prostatitis, there will be secretions. They get inspissated inside the prostate glands, and the inspissated things will get calcified. Then there will be endogenous calculi formation. Clinical features: incidental discovery on X-ray or during transrectal ultrasound examination or during TURP operation. It may manifest like chronic prostatitis. On examination, you will feel hard nodules in the prostate. Differential diagnosis: whenever you feel hard nodules, you must differentiate it from carcinoma of the prostate. Treatments: usually no treatment is required. If associated chronic prostatitis is present, means you have to treat it with ciprofloxacin or trimethoprim. In TURP, if you are doing TURP, if these calculi are present, means this also should be removed along with prostatic adenoma. So this completes the topic on disease of the prostate. Any doubts, please? If you have no doubts, we'll go to the next topic, that is the disease of the urethra and penis. To understand about the disease of the urethra and penis, we should have some detailed knowledge about the anatomy of urethra and penis. Acid phosphatase is exclusively present in prostate gland. No other organ has acid phosphatase. Okay, let's come back to the disease of the urethra and penis. The anatomy of urethra and penis. Urethra is having three parts. It starts at the bladder neck. It passes through the prostate gland, and that part of the urethra is called the prostatic urethra. Then it passes through the perineal membrane, and that part is called the membranous urethra and is surrounded by external urethral sphincter. Then it passes through the bulb of the penis, so that is called the bulbous urethra. Then ultimately it comes out through the shaft of the penis, so that is called as the penile urethra. The bulbous urethra and penile urethra both put together, they are also called as the spongy urethra, because the urethra is enclosed in corpus spongiosum. There are multiple glands opening into the urethra. They are called the urethral glands. And a pair of bulbourethral glands, they also open into the bulb of the urethra. This is a diagrammatic representation of the urethra. Then the penis, the part which is seen outside is called the shaft of the penis. The shaft of the penis is continuous with the root of the penis. The root of the penis is having two parts. A central part that is called the bulb of the penis, and two lateral parts. They are called the crus of the penis or crura of the penis. One on each side, one crus on each side. And central one is the bulb. So all the three put together, they are enclosed in a sheath. That's called the buccal fascia, and that is the shaft of the penis. The terminal enlarged part is called the glans penis. So you can see this is the shaft of the penis and this is the root of the penis. In the central part is the bulb and on either side the crura. All these three join together and form the shaft of the penis, which is situated outside the perineum. The expanded portion of the corpus spongiosum is called the glans penis. So this is the root of the penis and this is the shaft. So you can see the root here that is fixed in the or attached to the pelvic bone as well as to the perineal membrane. The crura and the bulb of the urethra, they have spongy tissue. This is also called the erectile tissue. So these three, the two crura and central corpus spongiosum, they continue into the shaft and they are surrounded by buccal fascia. So these two are the corpora cavernosa, and in the ventral side there is the corpus spongiosum, which expands itself into the glans penis. And this is the urethra. The urethra passes through the corpus spongiosum. The corpora cavernosa are mainly the erectile tissue that is helping for the erection. The corpus spongiosum is erectile as well as it transmits the urethra. So this is the buccal fascia surrounding the shaft of the penis. Over the buccal fascia is the collis fascia, and over that is the skin. You can see the arrangement of the skin. The skin gives a tubular extension to the penis, and it is attached to the buccal fascia behind the glans penis. So this is the glans penis. So there is a cover for the glans penis. So this cover of the glans penis is called the prepuce. Let us study something about the anatomy of the perineum. This is the lever triangle muscle. You can see this obturator tendinous on the side walls, and from the side wall you get the lever triangle muscle. This is also called the pelvic floor. So you can see this is pelvic floor. So you are seeing from outside the perineum, not inside the pelvic cavity. So seeing from the outside view. So this is the lever trine muscle. And of course, this is the gluteus maximus muscle. So this is the lever trine muscle. So this is the lever trine. Lever trine gives support to the pelvic viscera. It acts also as a sphincter. Now, underneath the lever trine muscle, you can see here, this is the rectal area. This is anterior. This is posterior. Okay, here is the coccyx. So here is the rectum. So our concern is for this part, this triangle part. This perineum is divided into two parts. It is a diamond-shaped structure. Two ischial tuberosities on either side. So, sorry, one ischial tuberosity on either side. In front is the pubic symphysis. Posteriorly is the coccyx. So now it makes a quadrilateral. You draw a midline across the ischial tuberosities. This divides the perineum into two parts. An anterior urogenital triangle. This is the urogenital triangle. Posterior anal triangle. So this houses the anal canal. So we have studied about the anal canal anatomy, anal canal triangle in the anatomy of anal canal. Now let us study about the urogenital triangle. So beneath the lever trine muscle, these muscle sheets are there. You can see the transversely arranged muscles. These muscles, there are two groups of muscles. One is the posterior one is called the deep transversus perineal muscle. So this is a muscle whose muscle fibers run horizontally across and they meet the other deep transversus perineal muscle. And in front of this one, there is one more muscle. This is the external urethral sphincter. So this muscle, what it does is, it encircles the urethra and gives the sphincter mechanism, which is voluntary sphincter mechanism, to the urethra. Between these pair of muscles and lever trine, there is pelvic fascia. So pelvic fascia separates the lever trine muscle from these two muscles. Okay? Now there is perineal membrane, a tough fascial sheet just below or just beneath the deep transverse perineum and external urethral sphincter. You can see here. This is the lever trine muscle. Beneath the lever trine muscle, there is pelvic fascia. Between the pelvic fascia and perineal membrane lies the external urethral sphincter anteriorly, posteriorly. The deep transversus perineal muscles are present. So there are two fascial sheets. One is the pelvic fascia and another is the perineal membrane. Between these two, there is a space. That space is occupied by these muscles. So this space is called the deep perineal pouch. This space is called the deep perineal pouch. This perineal membrane is attached to the ischiopubic rami on either side and anterior to the pubic bone and pubic symphysis. Posteriorly, it has a free border. To this perineal membrane are attached the bulb of the urethra and the crura of the urethra. Sorry, crura of the penis. So the crura are attached not only to the perineal membrane, but also to the ischiopubic rami on either side. In central region, you find the bulb of the urethra. So the bulb of the urethra is nothing but the expanded region of the corpus spongiosum. The corpus spongiosum is a long tubular structure. You can see here, this is the corpus spongiosum. This is a long tubular structure, which is having the spongy erectile tissue. The corpora cavernosa also has the erectile tissue in them. And this bulb and crura are surrounded by muscle. That is ischiocavernosus and ischiospongiosus. Through the corpora cavernosa, I already told you, the urethra runs. Then superficial to the bulb and crura, there is a fascia. This is called Colles fascia. This Colles fascia is fused with the posterior border of the perineal membrane here. On the sides, it is fused with the ischiopubic rami. Anteriorly, it continues to cover the scrotum. Here you can see it continues, and the green line is the Colles fascia. It continues over the scrotum. It gives tubular extension to the penis. Then it extends onto the anterior abdominal wall, where it is continuous with the corpus fascia. So this Colles fascia is continuous with this corpus fascia. Now, you have a space here between the Colles fascia and perineal membrane. This is the Colles fascia. Deep to it is the perineal membrane. So there are two layers are there. Between these two layers is the bulb of the penis as well as crura of the penis. Okay? So this space is called the superficial perineal pouch. So for the perineal membrane, there are two pouches on either side. The deeper one is called the deep perineal pouch. The superficial one is called superficial perineal pouch. So the superficial perineal pouch is having on the inferior side the Colles fascia, on the superior side perineal membrane. And this pouch is continuous anteriorly with the scrotal subcutaneous tissues and pineal subcutaneous tissues, and continuous with the anterior abdominal wall corpus fascia. I hope you follow this, because this anatomy is important to understand few diseases of the urethra. Okay, I will repeat again about the perineal pouches. Now you can see here, two sheets are there. The green tube is the urethra, and here is the bladder. Beneath the bladder is the levatrine muscle. So levatrine muscle is here. Over this white sheet is the levatrine muscle. Then you have the pelvic fascia. Pelvic fascia gets condensed and form a sheath here below the levatrine muscle. Then this is the perineal membrane. This white one is the perineal membrane. So between the pelvic fascia and perineal membrane is the space, is a pouch. So this is the deep perineal pouch. So my fingers are there in the deep perineal pouch, and here is the urethra. The extraurethral sphincter surrounds this urethra, and behind the extraurethral sphincter lies the deep transverse perineal muscle. Okay, the urethra comes below the perineal membrane, and now the urethra turns anteriorly like this. The urethra curves anterior and goes. Now you have a membrane here. This is the collis fascia. So this is the collis fascia. This is the perineal membrane. This is the pelvic fascia. Above the pelvic fascia is lever tranae muscle. Here is the collis fascia. So superficial perineal pouch means it is between the collis fascia and perineal membrane. Deep perineal pouch means it is between the perineal membrane and pelvic fascia. So deep perineal pouch contains the external urethral sphincter and deep transverse perineal. Superficial perineal pouch contains the root of the penis with their corresponding muscles covering them. Is it okay? So you can see here the collis fascia is removed. You are seeing the crura on either side, the bulb in the middle, the bulb continuing at the corpus spongiosum. And this is the ischiospongiosus muscle, and this is ischio-cavernous muscle covering these two structures. And posteriorly, you find a transverse muscle. This is superficial transversus perineae. So its counterpart is deep transverse perineae is there in the deep perineal pouch. The superficial perineal pouch contains superficial transverse perineal muscle. So this is the junction, a junction point where the external anal sphincter, superficial transverse perineal muscle, deep transverse perineal muscle deeply, and ischiospongiosus muscle all gain attachment. So what do you call this structure? The central structure into which all these muscles are inserted. Very good. This is called the perineal body. This is very important for the integration of the perineal muscles, especially in females. So this perineal body is important. Okay. So this is the shaft of the penis, corpus spongium, corpus cavernosum. This is the prepuce and glans penis. I hope you understood this. So this is the prepuce. This is the glans penis. This is the external urethral opening or distal urethral meatus. It is a vertical slit in the glans penis. This prepuce can be retracted backwards, exposing the whole of the glans penis. The posterior margin of the glans is called the corona glans. So with this brief review of the anatomy, now let us go to the congenital anomalies of the urethra. Meatal stenosis, congenital stricture of the urethra, hypospadias, epispadias, posterior urethral valves. So these are the anomalies. Meatal stenosis. So normally the meatus is a vertical slit like this. In some individuals, what will happen? This becomes a pinhole or circular round meatus. So causes congenital. This may be associated with phimosis. It may be acquired following meatal ulceration. So by any reason, if an ulcer occurs over the external urethral meatus, if it heals by fibrosis, then this meatal stenosis occurs. You can see here this white area. These are all healed ulcer. So this fibrosis. So it has fibrosed and then it left behind a small opening here. Clinical features: difficulty in micturition, effects of back pressure. So there will be, what are the effects of back pressure? Whenever there is lower urinary tract obstruction, so there will be back pressure effects. So what will be there as back pressure? effects. The back pressure effects will be there in the bladder, in the ureters, and in the kidneys. So tell me what will be there in the bladder? What changes you will find in the bladder due to back pressure effects? In BPH, what is the future of bladder? Bladder, what will happen? The bladder tries to overcome the obstruction. Yes, very good. It is called trabeculation. Trabeculation. So first, initially, there will be hypertrophy of the muscles. That produces a condition called trabeculation. Later, it leads to atony. Then it produces overflow incontinence and chronic retention. So the back pressure effects on the bladder will be trabeculation and later atony. The back pressure effects on the ureters is hydroureters. The back pressure effects on the kidneys is hydronephrosis. Ultimately, it will lead to chronic failure because it causes bilateral hydronephrosis. All lower urinary tract obstructions, they cause bilateral hydronephrosis. Treatment: meatal dilatation with Hager's dilators. These are the Hager's dilators. So with these dilators, you can dilate the meatal opening. You can go with meatotomy operation. Meatotomy means you enlarge the incision. You cut the meatus widely open. Meatoplasty. Once you cut it and leave it like that, again it will heal by fibrosis and the opening becomes narrowed. To prevent that particular thing, what you do is, after you cut it like this, then you take a small island of prepucial skin, inner layer of the prepucial skin, bring it forwards and suture it to the margins. So when you suture this prepucial margins here, then the margins will not stick or the margins will not fibrose. They will not adhere to one another. So this is called meatoplasty. The other condition is the congenital urethral stricture. It is rare. It may be associated with the duplication of urethra. Symptoms are delayed up to adolescence. Treatment is dilatation or optical urethrotomy. Optical urethrotomy means you will pass the cystoscope through the urethra. So while you are passing through the urethra, you will find the stricture area. So you take a knife and then cut it. So this cut is done under vision. This is called optical urethrotomy or endoscopic urethrotomy. Otomy means opening. So you cut open the urethral stricture. That is called optical urethrotomy. Then congenital posterior urethral valves. So there will be a membrane will be there in the prostatic urethra. This occurs in the posterior urethra below verumontanum. That is in the membranous urethra. It may be partial. So what is the importance of this membrane here? The membrane is there horizontally like this. So it will be horizontal like this. So it will stop the flow of urine downwards. But if you pass a catheter from below, it gives way to the catheter. So because it is like a semilunar cusp. So the catheter can go easily, and so you won't find any obstruction while you are passing the catheter. But if the patient wants to pass urine, these two cusps will come like this and they will cause the obstruction. So that's why this is called as the urethral valve. And they manifest usually during adolescence. They allow passage of catheter freely but impedes passage of urine. They produce back pressure effects. Treatment is suprapubic cystostomy. SPC is called as the suprapubic cystostomy. So leaving a catheter into the bladder is called a suprapubic cystostomy. For relief of the back pressure, then what you do is you pass an endoscope and you incise or resect that membrane that is there in the membranous urethra. Next condition is called the hypospadias. Hypospadias means the urethral opening, instead of opening at the tip of the glans penis, it opens on the ventral side of the penis. No, it is not a blind procedure. It is not a blind procedure. The valves are cut or removed with the help of endoscope. You pass a cystoscope, you look at the valves, and then you destroy the valves with cauterization. Hypospadias. Normally the urethra, this is the urethra. This is the corpus spongiosum. The urethra opens at the tip of the glans penis by a vertical slit. In some children, what happens is the urethra opens on the ventral side. Why? Because this corpus spongiosum has not completely developed. And where it has not developed, it becomes a fibrous sheet. So the fibrous sheet contracts. So whenever the fibrous sheet contracts, the glans penis is bent ventrally. So you can see here, this is the case of hypospadias, where the urethra is opened on the ventral side. Distal to this urethral opening, the corpus spongiosum is represented by a fibrous sheet. This fibrous sheet causes bending of the glans penis. And the prepuce in these patients, it is very long. You can see here the prepuce. So this is the urethral opening on the ventral side. Here you see on the glans a small pit. This is not the urethral opening. There is one small pit here itself. This is the glans penis, and this is the prepuce. Ventral side prepuce is absent. So it just looks like a hood. The external meatus opens on the undersurface of the perineum or undersurface of the penis, along with underdeveloped hood-like prepuce and bent penis. So this bent penis is called as the cardi deformity. And this cardi deformity is present distal to the urethral opening. So the urethral opening can be there on the undersurface of the glands. Then you call it as the glandular hypospadias. It may be there at the corona glandis. Then it is called coronal hypospadias. It may be there on the ventral surface of the penis, shaft of the penis. Then it is called the penile hypospadias. It may be there at the root of the penis. Then it is called the penoscrotal hypospadias. So classification is depending upon the site: glandular hypospadias, coronal hypospadias, penile or penoscrotal hypospadias, and of course if it is there in the perineum, we call it the perineal hypospadias. This perineal hypospadias is associated with cryptorchism, because whenever perineal hypospadias is there, scrotum is not developed well. So testis won't descend into the scrotum. It will be there inside the abdominal cavity. The scrotum is split in the midline. The child is mistaken for a female child. So you can see it. This is the coronal hypospadias. The opening is there on the shaft of the penis. So this is the urethral opening on the shaft of the penis. So this is called the penile hypospadias. This is the penoscrotal hypospadias, where the hypospadias is there at the junction of the penis with the scrotum. And this is the perineal hypospadias, where the scrotum is not formed. It is bifid. The urethral opening is here. Distal to the urethral opening, the corpus spongium is not developed. It is a fibrotic sheet, causing bending of the penis. So there is a cleft in the midline, the perineum, with the two scrotal folds on either side, and in the midline is the urethral opening. And in front of that is the bent penis. So if you look at this perineum in a newborn child, so it gives an appearance of a female perineum. That's why these children, though these children are male children, they will be mistaken for their gender, and they are brought up as the female children. Once the child comes to the menarche age and doesn't get menarche, then they will consult the doctor. So when examined, then it will be proven that this is a female child, not a male child. So this is perineal hypospadias. You see, this is the examples of perineal hypospadias. So here is this is something looking like a clitoris. This is the scrotum which is not developed, which is bifid. And here is the urethral opening. So here is the urethral opening. Pathology distal to the urethral orifice, the corpus spongium is fibrotic and produces cardiac deformity. The urethral orifice is usually narrow. Complications: backflow effects if the meatus is narrow. Difficulty in intercourse because of the cardi. Treatment depends upon the type of the hypospadias. Because the urethral opening is not there at the tip of the penis, the child can't pass urine like this. It will be jetting downwards. And actually, for the school-going children, so they always compare with their friends or colleagues. So everyone will be able to pass the urine with a stream like this. But the hypospadias children, they feel they get the inferiority complex because they can't get a stream like that. So for glandular hypospadias, no treatment if the meatus is not narrowed. Meatotomy if meatal stenosis is present. Other types surgery. So there are very many surgeries for this. They are all called the urethroplasty operations. So for hypospadias, the urethra is again reconstructed to come to the tip of the penis. So the details of the procedures are not required. But here I want to mention about this particular technique. This is called Asopa's technique. He is an Indian surgeon from Agra. So he has devised a wonderful surgical procedure for this, which is being followed in many centers across the world. And there is another procedure called Duckett's operation. There are not two, these are not the two. There are many, many other operations. So the details of these procedures are not required for an undergraduate student. So removal of the fibrous corpus spongium distal to the urethral orifice to release the cardi, reconstruction of the urethra with skin flaps or buccal mucosa to open at the tip of the penis. Then epispadias. It is very rare. Urethral opening is on the dorsal side with the dorsal curvature of the penis. Total epispadias is usually associated with ectopia vesicae. Then after congenital diseases, the traumatic disease of the urethra, that is the rupture of the urethra. Classification: rupture of the bulbar urethra and rupture of the membranous urethra. So this is the bulb of the urethra and this is the membranous urethra. So these two parts are the prone for rupture. They may be partial rupture or complete rupture. First, let us learn about rupture of the bulbous urethra. Cause injury to the perineum by falling on bicycles, loose manhole covers, etc. So in the rainy season, there is a big problem in the cities. So there will be manholes will be there. They are not properly closed. So loose manhole covers will be there. So in the raining condition, when the water is flowing over the road, people will not be able to know where manholes are present. So if they accidentally put their foot on the manhole like this, then because it is not completely closed, so it may slide to one side. So the person may slip and his perineum will come and hit over this edge of this manhole. Similarly, a person riding on the bicycles, he may slip from the seat and may fall over the front rod of the bicycle and may get injury to the perineum. So now the urethra gets compressed between the manhole cover and pelvic bone. How it manifests? There is triad, there is perineal hematoma, retention of urine because patient has sustained injury to the urethra, the urine will not flow, and there will be bleeding from the external urethral meatus. Complications: extravasation of urine. So we have seen this collis fascia. This green color layer in the collis fascia. This is the corpus spongiosum, this is the urethra, and here is the perineal membrane. So in the deep perineal pouch. So in the deep perineal pouch is the external urethral sphincter and membranous urethra. If a hit occurs to the perineum, there is tear of the corpus spongiosum with tearing of the urethra inside the corpus spongiosum. Now when the patient wants to pass urine, the urine comes up to here. From there it can't go downwards. So what will happen? There is associated rupture of the corpus spongiosum also. So the urine now leaks out here and collects here. So where does it go? This is the collis fascia. This collis fascia is fused to the perineal membrane posteriorly. So the urine collects under the collis fascia. The urine cannot go behind the perineal membrane. That means over the midline of the perineum. So on the sides, there is ischiopubic rami. That means it occupies the superficial perineal pouch. So the urine collects in the superficial perineal pouch. We have seen that this collis fascia gives a covering to the scrotum and penis. So under this collis fascia, urine collects. So the scrotum and penis, they get swollen with urine. Then the urine spreads under the corpus fascia because the collis fascia continues at the corpus fascia. So there will be collection of urine between the linea alba and external oblique aponeurosis internally and outside this corpus fascia. So between this, in this plane, it spreads up to the level of the clavicles. So because corpus fascia is continuous with the subcutaneous tissues of the abdominal wall, so the urine goes in the subcutaneous plane. And below into the thighs, this corpus fascia is fused to the fascia lata. So up to that fusion line, the urine collects. So below that line, the urine cannot go. So this is how the extravasation takes place. So this is the graphic representation of the superficial extravasation of urine. In the perineum, it will be like this. Laterally, it will be there up to the scopubic rami. Anteriorly, it extends over to the scrotum and penis, and then it extends onto the anterior abdominal wall up to the level of the clavicles. It won't go into the thigh, so because corpus fascia is attached below the inguinal ligament to the fascia lata, so it stops here. So this is the clinical appearance of a patient with superficial extravasation of urine. This fellow sustained injury to the perineum by falling on a bicycle. So then his urine has extravagated into the perineum. Then it has caused boggy swelling of the penis and scrotum as well as the lower abdomen. And if it continues to pass urine, it will collect even up to the clavicles. Investigation is urethrography, wherein you inject a radio contrast dye into the urethra through the external urethral meatus. You will notice the place where there is the rupture in the urethra. Treatment: first of all, you must divert urine, otherwise the extravasation will increase. The extravagated urine will cause cellulitis. So what you must do? You must do suprapubic cystostomy and delayed repair of the tear. That means after the edema and extravagated fluid, everything subsides, then you do urethral repair. This is by urethroplasty operation. Then next condition is the rupture of membranous urethra. We have just now discussed about the rupture of bulbous urethra. Now rupture of the membranous urethra. Membranous urethra means that part of the urethra which is situated in the deep perineal pouch. Causes fracture of pelvis, penetrating injuries, rare. So most commonly due to membranous urethra rupture is because of fracture of the pelvis. This is the bladder, this is the prostatic urethra, and here is the perineal membrane. So whenever there is fracture of the pelvis, the puboprostatic ligaments, they get torn, and there will be tearing of this membranous urethra. So because puboprostatic ligaments are also torn, the prostate gets displaced backwards. And when the patient urinates, urine won't come out through the external urethral meatus, but urine extravagates here in this space. So in this which space? Here is the peritoneum. This is the bladder. So urine collects in the pelvis extravasically, then it spreads onto the anterior abdominal wall, and it goes between the peritoneum and fascia transversalis. That means in the space of Bogros. The same space of Bogros is the space where urine extravagates when there is rupture of extraperitoneal bladder. So even if the bladder is ruptured here, the same space will contain extravagation. So when the membranous urethra ruptures, then also there is extravagation into this space. So this is called deep extravagation. The bulbar urethra rupture produces superficial extravagation, while membranous urethra rupture and bladder rupture produces deep extravagation. So clinical features: there are multiple trauma, retention of urine, bleeding per urethra, and there is associated rupture of bladder may be present. Treatment: suprapubic cystostomy, and later optical urethrotomy or urethroplasty operation. Or when the patient comes early, you can do a procedure called railroad repair of the urethra. So in this, what will happen? What you do is, you do first suprapubic cystostomy. You pass a metal dilator through the bladder into the internal urethral meatus, from there into the prostatic urethra. So from there onwards, it won't go down because there is rupture of the urethra here. You take another metal dilator, pass it through the penis, and pass into the bulbar urethra, then it won't pass from this point because there is tear of the membranous urethra. So what you do is you manipulate these two dilators in such a way that the tips touch each other. So by getting metallic sensation, when the tips touch, you will notice that they are touched one another. Then what you do, you advance this dilator carefully into the bladder. So once they get aligned, then you advance this metal dilator into the bladder. So once it goes into the bladder, you get it through the suprapubic cystostomy opening out. Tie a thread to the tip and you pull the thread out. The thread comes out like this. So now the thread is coming from the abdominal opening, coming through the urethra, coming outside. To this thread, you tie a Foley's catheter and gradually pull it inside. So the Foley's catheter will go into the bladder. Once it goes into the bladder, you inflate the balloon and keep it there for about 3 weeks. Then the urethral rupture gets aligned to one another. So this is called the railroad technique of repair of membranous urethra. Some people, what they do is, instead of the dilator passing through the suprapubic cystostomy, they place their finger because they will have better tactile sensation. And this is called Shaw head and Shaw procedure. Extravasation of urine. Types: superficial and deep. Already I explained to you the superficial and deep. Superficial extravasation is limited by attachments of the collis fascia, posteriorly up to the mid-perineal point, into the thighs just below the inguinal ligament, anteriorly extends into the scrotum and penis, above extends to the abdominal wall between the scarpus fascia and abdominal muscles. I hope you understood the anatomical planes of this superficial extravasation. Then deep extravasation causes extraperitoneal rupture of the bladder and intrapelvic rupture of the ureter, that is the membranous urethra rupture. Extravasation occurs into the layers of the pelvic fascia and extraperitoneal space, that is in the space of the bone-growth. Treatment: suprapubic cystostomy and retropubic space drainage. No, it is not between the superficial extravasation is between the scarpus fascia and external oblique aponeurosis. It is not between the skin, it is underneath the scarpus fascia it goes. Okay? The next topic is the inflammations of the urethra. It is urethritis. It is produced due to gonococcal commonly or non-specific, and the other cause is called Reiter syndrome, permeatal ulcer. Gonococcal urethritis. It is a sexually transmitted disease caused by Neisseria gonococci. Lesions in males: the anterior urethra, oropharynx, rectum and anal canal. In females, urethra, cervix, fallopian tubes, they are commonly infected. Sometimes there may be infection of the oropharynx, rectum and anal canal. So when abnormal sexual practices have been practiced, then these will also be infected. Clinical features in males is scalding micturition, other means burning micturition, discharge of pus from urethra. In females, symptomless, there may be mild dysuria. Investigations, bacteriology of the urethral discharge. Gram staining shows gram-negative cocci. Complications, early complications, spread of infection to the prostate, seminal vesicles, epididymis. Periurethral abscess. We have seen that there are periurethral glands are there. So whenever there is urethritis, that means urethral mucosal inflammation and infection, the infection can spread to the periurethral glands and they cause the abscess. This can lead to sepsemia, iridocyclitis, arthritis, endocarditis. Late manifestations being stricture of the urethra in males and infertility with bilateral tubal infection in females. So if the bilateral salpingitis occurs due to gonococci, they get fibrosed and strictured. So that's why the woman will go into the infertility. Treatment is antibiotics, high dose penicillin and ampicillin. In penicillin allergic patients, you have to go for kanamycin, tetracycline. Non-specific urethritis. Etiology, idiopathic in 40% of the cases. In remainder, due to infection by chlamydia, trachomatis, and ureaplasma urolithica. Clinical features, there will be dysuria, mucopurulent urethral discharge, rarely results in stricture of the urethra. So there will be chronic urethral discharge with little amount of burning pain. Treatment is tetracycline or doxycycline for both the partners. Reters disease. It is called sexually acquired reactive arthritis. There will be subacute urethritis, conjunctivitis, anterior uveitis, arthritis. In few cases, there will be keratoderma, blenrosicum of the heels and soles of the feet with nodules, vesicles, and ulcers on the sole. It is a non-gonococcal infection, but it is sexually acquired. Differential diagnosis is different from gonococcal arthritis, urethritis, wherein there will be short incubation period and presentation is severe in case of gonococci. Next condition is the stricture of the urethra. Causes, congenital stricture, traumatic stricture following rupture of the urethra, then inflammatory stricture following gonococcal urethritis, and post-urethral chancre, rarely due to tuberculosis. Then it can be due to instruments like indwelling catheter. So one of you was asking me in the previous class, will indwelling catheter cause any complications? Yes, it causes chronic urethritis, and that can lead to the stricture of the urethra. Then following urethroscopy, if there is any injury to the urethra, then that can lead to a stricture formation. Post-operative, after open prostatectomy, then after surgery called amputation of the penis. Pathology, in post-gonococcal infection, if the infection is inadequately treated, it leads to periurethral gland infection, heals by fibrosis, and that leads to stricture formation. The commonest site of stricture is bulbous urethra. Most of these appear within 1 year of infection, but may present 10 to 15 years later also. Clinical features, difficulty in micturition in young patients, poor urinary stream, which improves on straining. Sometimes there may be acute retention of urine, usually follows postponement of micturition due to drugs, sedatives, or social reasons. Investigations: cystourethropy, urethropy. So in urethropy, you can make out the extent and tightness, how much narrowing is there. So this is a urethroscopy. So when you pass the urethroskop, you can make out this structure here. This is urethrogram. So you take a dye in the syringe and push the dye through the external urethral meatus. So the urethra is filled with the dye. So you can see here a narrowing. So this is the stricturous area. Sorry. So sometimes there may be urethral fistula associated with urethral stricture. Complication of stricture: retention of urine, urethral diverticulum. Due to chronic straining, patients may develop hernia, hemorrhoids, prolapse of the rectum. Peritoneal glands may be infected, causing peritoneal abscess. The abscess may burst open outside, producing periurethral fistula, spreading cellulitis and fistula. This fistula is called the watering can perineum. So you can see here, this is the scrotum. You see here the periurethral abscess. The abscess bursts, patient may develop multiple fistula in the perineum. And when the patient is passing urine, the urine comes out through the extraurethral meatus, and it also comes through these fistulas opening outside. So because when the patient is passing urine, so there will be 4 or 5 streams coming from the perineum down. So it looks something like a watering can. So this type of urination will be there from the perineum. That is why it is called the watering can perineum. Treatment of stricture of the urethra: intermittent dilatation by buoys or dilators. There are metal dilators called the Lister's and Clayton's buoys. There are gum elastic buoys. The second type of procedure is called the internal or endoscopic optical urethrotomy, urethroplasty. In urethroplasty operation, you do excision and end-to-end anastomosis for short strictures, patch urethroplasty with buccal mucosa, penile skin, or lingual mucosa. That means strictured area is removed. If it is close to one another, you can do end-to-end anastomosis. If some gap is there, then you take a free buccal mucosa. So you take the buccal mucosa and make it like a tube and you graft it in between these 2 cut segments. And you pass a catheter and keep it for a week or 10 days. So this is called the patch urethroplasty. So you can do either end-to-end anastomosis or you can do the patch urethroplasty. And the standard procedure nowadays is the endoscopic urethrotomy. So wherein you pass the cystoscope, you will find the tight stricture there. With a small diathermy knife, you make a cut at 12 o'clock position and pass a catheter and leave it there for about 10 days. This is called the internal or optical urethrotomy. In earlier days, the procedure is called the dilatation. So these are called the dilators. So there are various dilators will be there of various diameters. So you start from the small one and gradually pass one after the other. So the stricture gets dilated. So this dilated stricture will be kept dilated for only few days. Again, when the patient gets narrowed stream, you have to do dilatation. So this is a blind procedure. This can have some complications. That is why nowadays it is not being practiced. The procedure that is being practiced nowadays is the optical urethrotomy or endoscopic urethrotomy. Then periurethral abscess. Classification: acute, It can be over the shaft of the penis or the bulb of the penis. And chronic. Acute penile abscess occurs due to infection of the glands of the urethra, usually results in fistula. The bulbous abscess occurs usually due to stricture of the urethra. There will be spreading cellulitis to the perineum, penis, and anterabdominal wall. Tender swelling with general features of abscess. Treatment: antibiotics, insistent drainage for the abscess. And it is safe to divert urine by doing suprapubic cystostomy. Otherwise, if the abscess is open, there is leakage of urine to the superficial perineal pouch. Chronic abscess, it occurs following long-standing stricture, results in urethral fistula following surgery of abscess or spontaneously. Treatment: insistent drainage of the abscess and treatment of the stricture. Urethral fistula, it follows bursting or incision of periurethral abscess following urethroplasty operation, sometimes present with multiple external openings. That's called the watering can perineum. Treatment of the stricture and urethroplasty operation. Urethral calculus. Primary means formed behind the stricture or in an infected urethral diverticulum. So because whenever stricture is there, proximal to that one, there will be stasis of urine. So in the stasis of urine, there may be calculus formation. Similarly, if a urethral diverticulum is present, so the diverticulum may house a stone. Secondary means the calculus which is migrated from the bladder. Female urethral diseases, prolapse of urethral mucosa. This is also called as urethrocoele. This is associated with prolapse of the uterus. The stricture of the urethra, this occurs following urethritis or trauma of difficult raba. Fowler syndrome. This is abnormal myotonia in striated sphincter, that is external urethral sphincter. So the patient will have difficulty in passing micturition. Actually, there is no stricture, but it presents like stricture. But when you pass a catheter or a dilator, it passes in easily. There is nothing but there is excessive tone in the external urethral sphincter. The cause is not known. Treatment: intermittent self-catheterization. The patient can be advised to do catheterization by after washing hands. So that will keep the passage patent. Urethral diverticulum cause difficult labor with injury of the urethral muscle. That causes diverticulum. Then urethral caruncle. It is a pedunculated granuloma arising from the posterior wall of the urethra near external urethral orifice. So you can see here is the vagina and this is the urethra. So from the posterior urethral wall, you find a granulomatous mass, a polypoidal granulomatous mass. This occurs in elderly females. Complaint is dysuria and frequency. Differential diagnosis is urethral prolapse. Treatment: excision and diathermic coagulation of the base and antibiotics. So this is the urethral caruncle. This is one of the frequently seen conditions in the middle-aged women. It is seen in the middle-aged women. So this manifests with the features of dysuria and frequency of urination. So this is nothing but a granulomatous polypoidal mass arising from the posterior wall of the urethra near the urethral orifice. So when you look at the urethral orifice, you can make out on clinical examination. So the treatment is very simple. You take a bipolar forceps, bipolar diathermy forceps, and you coagulate and remove this one. Carcinoma of the urethra. The frequency of micturition is there because of the granulomatous mass causing irritation. So because of the irritation, the patient always feels like passing urine. So that is what that causes the frequency. And for the same irritation, there will be dysuria or burning micturition. Carcinoma of the urethra is more commonly seen in women. Probably the pre-malignant condition is the caruncle. Caruncle may be a pre-malignant condition. Clinical features, you feel a hard plaque in the urethra with a narrowed stream. Treatment is by radiotherapy or by excision. So this is about the disease of the penis, disease of the urethra. Now we will study about disease of the penis. Because we have started the class a little bit late, so let us have a 5-minute talk on this topic also. So shall I continue for another 5 minutes? Okay. Injuries to the penis. Avulsion of skin of penis. We have seen that penis is having corpora cavernosa, ventral side, corpus spongiosum. All these three corpora are enclosed in a tough fascia called the Buck's fascia. And over the Buck's fascia is the collis fascia. And over the collis fascia is this tubular skin. The skin is not adherent to the underlying structures. It is loosely placed. That's why whenever a traction injury occurs to the penis or penile skin, the skin may be avulsed. Causes entanglement of clothing in a rotating machinery, or sometimes the injury to this penis can be due to jip. That means the pant, the jip of the pant, when the fellow is fastening it, it may accidentally cause injury to the penis. Treatment, repair by skin grafting. Temporarily penis can be buried in the scrotum. So you can see this patient was working in a mill where a rotating machinery is there. So he was dumping some material into that machinery and accidentally his clothes were caught in that machinery. So he was turned around and accidentally his penile skin was entangled in the clothes and it got avulsed. Then skin grafting was done for this. So sometimes the trouser will have the jip, and when the fellow can have this type of injury. Then fracture of the penis cause forceful bending of the erect penis during intercourse. Clinical features, there will be painful swelling of the shaft of the penis due to extravasated hematoma. You can see here there is a lot of extravasation of blood from the corpora cavernosa. The corpora cavernosa is torn. Investigation, MRI scan of the penis. Treatment, incision and drainage of the clot and suturing of the defect in the torn sheath of the corpora cavernosa. strangulated penis. Sometimes for fun, some people they place metallic rings over the penis for abnormal sexual gratification. So because of this presence of the ring, there will be engorgement of the penis distal to the ring. Then the fellow cannot get it out. That may cause the strangulation of the distal part of the penis. Treatment: aspiration of corpora cavernosa and try to extract the ring. If it is not possible, then with an hacksaw you have to cut the ring and remove it. With ligature of silk string, the silk string is passed proximally through the metallic ring and the silk was wound around the penis 10 to 15 times just below the metallic ring. The metallic ring is then slid distally down the penis and ring removed. Of course, this is not a easy procedure. You can see here the tight ring is placed at the penis. So silk is passed underneath it, and with it is gradually being pulled forwards. You can see the mark of the ring here. Sometimes you can produce gangrenes like this. Phimosis. This is the prepuce. The prepuce is having two layers, an outer layer and inner layer. The outer layer is called prepucial skin. The inner layer is called prepucial mucosa. So you can see this white layer, that is the inner layer. This is the outer skin. Actually, it is being retracted backwards. That's why you are able to see the inner layer here. Phimosis is narrowing of the prepucial orifice. The prepucial orifice. Normally, the person will be able to retract the prepuce over the glans. But when the person unable to retract it because there is narrowed prepucial orifice, then it is called the phimosis. Phimosis is an important topic for you in the theory examination. Causes: congenital, it may be associated with meatal stenosis, occur usually in children, should not be confused with normal additions between prepuce and glans in children up to 6 years of age. Acquired due to thickened and non-pliable foreskin due to Balanitis gerotica obliterans. So in usually adults, the skin becomes thickened. This is because of a condition called Balanitis gerotica obliterans. So where the elastic material that is there in the dermis is replaced by fibrous tissue. So it contracts and causes narrowing of the prepucial orifice. This condition can spread to the glans penis, causing meatal stenosis, and is rare before age of 5 years. Complications of phimosis: back pressure effects. The back pressure effects are usually due to meatal stenosis. When the prepuce can't be retracted backwards, it is difficult to keep penile hygiene. Recurrent attacks of cracks can develop in the prepuce following intercourse, and there can be development of melanoposthitis. Melanoposthitis means this infection of the prepuce and glans. It is called melanoposthitis. So you can see here multiple cracks developing over the prepuce. So this is the case of melanoposthitis. Treatment: circumcision. That means you cut the prepuce. You cut the outer skin, then inner mucosa, then suture the outer skin to the inner mucosa. So the prepucial skin is removed. This is called circumcision. Okay. We will discuss about circumcision in the tomorrow's class. Any doubts, please? Okay, if you have no doubts, I will close this session. Back pressure effect means whenever there is lower urinary tract obstruction, that means from bladder neck to the external urethral meatus, if some obstruction is there, then what the bladder will try to do? The bladder will try to overcome the obstruction by exaggerated pressure. And patient also will try to apply more pressure by abdominal wall contraction. So this produces more pressure in the bladder. But urine is not going forwards because there is an obstruction there. This causes reversal of flow. So there will be reversal of flow into the bladder, into the ureters, into the pelvis of the kidney. There is back. So there will be back flow or reversal flow. So this back flow will be there under pressure. So that is called the back pressure effect. So whenever there is lower urinary tract obstruction, that leads to the back pressure on the bladder producing trabeculation, back pressure onto the ureters producing hydroureters, and back pressure onto the pelvis of the kidney producing hydronephrosis. Okay, are there any more doubts? Okay, thank you. See you tomorrow at the same time.